size or in terms of shape, it will be far worse actually, for an anaplastic cell than a dysplastic cell. And usually when you say the word anaplasia, when you label a tumor as an anaplastic tumor, you're really telling the treating physician that your patient is doomed, really, because a diagnosis of anaplastic, let's say thyroid cancer, is a very short-term diagnosis. Your patient is very likely to succumb to this diagnosis within a very short period of time because it is a highly invasive, highly destructive type of tumor. All right, so the two, both of them actually refer to a diagnosis of cancer, both anaplasia and dysplasia. There is no difference except the severity of the findings. So you will see, for example, for an anaplastic cell, the anaplastic cell, sure, it is a dysplastic cell, but it is, for example, a very large dysplastic cell. The size of the anaplastic cell will be probably 8 to 10 times that of a dysplastic cell. The nuclear, borders of the, anaplastic cell will be far more irregular. There may be actually, tumor giant cells with anaplasia in an anaplastic tumor. There may be actually also not just abundant mitosis, but abundant and also very, very strange looking mitosis. They call it star shape. They call it tripolar. There are many names for it. A smudge mitosis. All of them actually refer to a cell that is highly, malignant. And this is how you would be able to look at anaplasia versus dysplasia. So here's an example of an anaplastic tumor. So let's say, let's talk about actually which one is a dysplastic cell. This is a dysplastic cell right here. How would you know that it's a dysplastic cell? You look at the nuclear border, and the nuclear border is irregular. The nuclear size have increased significantly. The cytoplasm is only a rim of what it was before. So the nuclear cytoplasmic ratio is very high, as I mentioned to you. So right off the bat, this is actually a malignant cell, a dysplastic cell. You also, add to it a little bit of, features, and that will solidify your diagnosis even more. Look at the prominent nucleoli that this, cell is having. So all of those are features of a dysplastic cell. Now compare this dysplastic cell with this actually cell right here, or with this cell, or with any one of those. This looks like a rookie, right? It looks like really a milder form of, of cancer, if you will, compared to those. Those are much more larger. This is one, two. Not only this one started to fuse up, resulting in the formation of a tumor giant cell. Okay, so compared to this, it's definitely this one looks very, very mild compared to that. But both of them are cancerous cells. So if a tumor harbor this kind of features, much larger cells, much irregular border. Look at the border. The nuclear border here is pretty, round, right? Compare that to this one here. Here it is irregular, regardless if it is multiple nuclei or not. These used to be actually single nuclear cell before it start to fuse with each other, giving rise to the, the giant cells that you're looking around, that you're seeing around here. All right, so that's all. The nuclear border is very irregular. Look at the chromatin. The chromatin here, there's chromatin clearing. The chromatin is not so clear here. There is a prominent nucleoli for sure. The NC ratio is absolutely through the roof. And the fact that actually that it is a giant cell. Now, if you look here, where are we now? What are these cells surrounding this? So that shows you also like how bad this tumor is. You are actually, the space that you're looking at now is a vessel. So these tumor cells are inside a vessel. That's what you call vascular invasion. So those, tumor cells manage to get into those vessels, invade the vessel, and they are going with the flow. They go as an indication of how aggressive and how bad this tumor is. Here's another example of a anaplastic tumor. If you look at these cells, you will start to see that most of these cells, even the nuclei, are actually becoming very fade. When a cell, started to have its nucleus fading, what is happening to that cell, in your opinion? When the cell, I mentioned that to you before, how would you know that a cell is dead? When you start to see only red, right? Only red. That's exactly what you're looking at here. You're starting to see more red than blue, actually far more red than blue. Maybe this is blue, but the rest is, and this is blue probably as well, the rest is red. So these are dead cells. This is what you see in high-grade tumor. So high-grade tumor, why? Because the tumor is so robust in terms of proliferation, it will outstrip its own blood supply. So as a result of that, there will be large swaths of the tumor that are going to die. So that's exactly what happened here. And the result of this is going to be death. Not only this, if you look at here, and you will see this star-shaped mitosis. That's a very peculiar looking mitosis, very irregular kind of mitosis. This is not how mitosis looks like. And that's exactly what you see also in high-grade anaplastic tumors. Again, the pleomorphism, your friend who was here who asked me about pleomorphic versus monomorphic, she's not here anymore. I could have given her a good example here. So here you see cells of all different sizes and shapes. The reason for this is that the regulatory mechanism that used to produce those cells that look like each other in that site, in that tissue, is no longer actually functioning. It's kind of dead, really, or it's kind of gone. So the end result is going to be cells that simply, takes, the shape of pretty much everything. So look at this, very strange looking cells of all different sizes and shapes. And then the tumor giant cell that we have seen a second ago. All right, so rate of growth. In general, a benign tumor is slow growing tumor. That's in general, in 99% of the time. There are exceptions to the rule, and you will probably read about the exceptions, but it's only the exception. The rule is that a benign tumor is a tumor that is slowly growing, okay? And by doing that, why is that the cause? The reason for this is that the genetic mutation behind it, or the genetic drive behind it, is a weak drive. Remember the independent word that I gave you in the first lecture. So it is weakly independent. It does actually give rise to more of its own, but it is really limited in terms of ability to grow very fast. That's number one. Two, actually, it will grow by an expansile kind of fashion. So it will not infiltrate in nearby tissue. It will not send cords of cells invading nearby tissue. It will simply grow slowly and very respectfully, compressing the nearby tissue. By compressing the nearby tissue, it will create a pseudo capsule from the nearby tissue that is going to surround those tumors. Okay? So as a result of that, the benign tumor will be encapsulated tumor. Whereas the malignant tumor have a much higher ability to grow, a much faster ability to grow. So it will grow fast, it will give rise to a mass that is very large, very soon, and it will grow by simply sending actually those cells in nearby tissue, creating what you call irregular membrane, irregular borders, because it is not growing by expansile kind of growth pattern, it's going by infiltrating style. And by doing this, it will create a nightmare for the treating surgeon. Because when you go inside and you try to take out this tumor, the malignant tumor, you will not be able to shell it out in one piece. The reason for this is that you don't know really how far the tumor cells have infiltrated in nearby tissue. So you have to, as the surgeon, you have to keep shaving and sending to pathology until the pathology will let you know what is known as a clear margin of resection. When that happens, you know that you have actually reached an area where there are no tumor cells that have reached. And by doing this, you're going to actually, have attempted to remove, the majority of the tumor out, okay? All right, so we did talk about mitotic figures. We did talk now what happens as a result actually of the fact that this tumor is growing very fast. It will grow so fast, it will outstrip any blood supply that is available to that tumor mass. In the process of doing so, there will be large areas of the tumor that will die. And that is going to be in the form of necrotic areas. How will that look like? Necrotic areas will look like, when it comes between actually the gross naked microscopic naked, with your naked eye examination and that of the microscopic examination, on the gross morphology, you're going to see those actually necrotic area as depressed area. It's going to be depressed. So if you look at it from the side, you will see that the areas that are still intact are still actually holding up, and the areas that have died have depressed. So you will see depression areas within the solid surface of the tumor. And also you will see that there will be areas of hemorrhage. And the reason why this is hemorrhagic, the malignant tumor mass, the malignant, not the benign tumor mass, is the fact that actually the tumor cells have, have proliferated so much that, there is very little blood that is going to be enough for them. So what happened is that the tumor cells are going to resort to upregulation of certain mechanisms that will make new blood vessels. Those new blood vessels are going to be leaky blood vessels. Leaky, allowing for the leakage of RBCs in those areas. Why? Because it's a new blood vessel where the fenestration, the endothelial fenestrations are not completely intact. So they are still leaky. That's why actually you start to see a lot of blood oozing in those malignant tumors because of the new vascularization that is happening. So here's an example of a normal colonic epithelium right here. Pretty much everything looks the same. Compare that, and if you look at the size of the nucleus, and where is the nucleus located, you will see that the nuclei are located actually towards the bottom of the pit, towards the base. If you look at the size of the nuclei of this adenoma right here, colonic adenoma, you will see that it is much more larger than this. Even a benign adenoma, the nuclei are going to be much more than this. Not only that, you will look at the mitosis. The mitosis here is limited to the basal layer. If you look here, the mitoses are actually all the way up. So even in benign tumors, there is a brisk mitotic activity, far more than what you see in normal tissue. But one, you will not see it as abundant as malignant tumor. This is one. Two, you will see that, for the most part, it will actually have a normal, morphology to it. You will not see the star-shaped or the tripolar or the smudge or the long list of, strange-looking mitosis that you see in malignant tumors. So here are examples of mitosis that you see in malignant tumors. Look at this. The cell is completely smudged. The nuclei is completely smudged. And there is an explanation for this, because what happened as a result of the carcinogenesis that has affected the cell, the chromatin of the cell becomes very fragile. So when it starts to divide, the chromatin is going to break. And that's exactly the reason why you're seeing this very peculiar, configuration. It may break and becomes like a smudge cell. It may break in several pieces, like the star, shaped mitosis that you have seen, tripolar mitosis, as you have, as you can see here. So all of those are indications of the fragility of the chromatin of the cancerous cell. Local invasion. For the most part, benign tumors do not invade nearby tissue. This is, again, the most common, rule, if you will, to this. But there are tumors, actually. There are benign tumors that are, aggressive. So, again, medicine is all about, unfortunately, exceptions, and there are exceptions to the rule. Again, how would a benign tumor grow? It will grow in this expansile pattern. It will not grow as an infiltrating pattern. Example of that, what happens with malignant tumors. Malignant tumors, they grow by infiltration. Okay, they grow and they spread by actually invading nearby tissue, and in the process of doing so, creating these irregular borders. All right, here's an example of benign tumors. Both actually right and left pictures are examples of benign tumors. You can see this is a hepatic adenoma, a subcapsular hepatic adenoma, usually in someone who was actually taking, the birth control pills. There is an association between the OCP, the oral contraceptives, and development of hepatic adenoma. A subcapsular here, right here, but what you see about it is that first is that it is encapsulated. You agree with that? That's number one. Number two, it is devoid of hemorrhage or necrosis. 3, it is minding its own business. It's not really infiltrating in nearby tissue. Compare that to also this here, the 3 examples that we have talked about, the subserosal, the myometrial, and the subendometrial leiomyomas. Each one of them is well circumscribed, encapsulated, freely movable, devoid of any necrosis or hemorrhage. So all of those are actually indications that what you are dealing with are benign, are benign tumors. Okay. Here's an example, on the other hand, of malignant tumors. You look at the borders of this tumor, and right off the bat, you realize that it is a regular border. This is 1. 2, it is in the fat. 3, it is pulling the nipple down. 4, it is large. All of those are indications that what you are dealing with is actually a malignant tumor. And then comes, I would say, solid indications. Then comes really the gold standard. And this is the lymph node that was dissected from the same axilla, on the side of where the tumor grew. And when on sectioning, it turned out that actually, the tumor that is here is exactly the tumor that is here in terms of morphology. This is the most solid kind of indication that you need to call that a metastatic adenocarcinoma of the breast. All right, so metastasis. Again, metastasis, benign tumor for the most part do not metastasize. Again, there are exceptions to the rule, but you don't worry about the exceptions because you want to learn the rule first. Malignant tumors, on the other hand, by decree, by accord, actually they metastasize. Now, that's an important actually feature. As I mentioned to you, this is the short of invasion. This is the most solid gold standard to differentiate between benign tumor from malignant tumors. How does the invasion happen? The invasion happens, the invasion that happens, by a malignant tumor happens, to the lymphatics or to the blood vessels, usually the veins, or through actually body cavity, and that's how the metastasis that will happen from this invasion. And usually what happens actually when there is a metastasis, let's say from the colon as an example to the liver, the metastatic cells that have escaped the colon tumor and ended up in the blood will not be one cell. It will be many number of cells, millions of cells actually. So when they actually reach a site, in this case, it's going to be the liver, and that's due to the portal circulation. Everything from the GI goes, to the liver. What's going to happen is that each one of those cells have the theoretical ability to establish metastasis in the liver. So you will see that a primary tumor is usually a single mass. Metastatic tumor are usually multiple masses, and that's an important actually distinction feature. So you will see, what they call in the US and the UK, they call it a pump shotgun appearance. And the pump shotgun, right? The ones carried by Arnold Schwarzenegger, in the Terminator movie. That usually takes about, 3 or 4 people to carry it. He's carrying it on his own, alone, right? And then he's shooting with it. The way that it will kill is that it will spread in the form of actually, a field of effect. It will not be a single bullet. So this is exactly what happened. This is a field effect because so many of those emboli are going to end up in that organ, and that's going to result in the development of metastasis. So that's one. Also in the UK, the UK are, probably they don't use the pump shot. They use actually another word for it called cannonball. They go back in history. The UK is a classic place, so they always, go back to history to use some of the, of the names from history, from their history. Cannonball appearance. And that's what you're going to be finding. So the minute you see metastasis, that's going to be most likely to be associated with actually a metastatic tumor. The primary, most of the time, will be a single mass. Remember that. All right. So this is a summary of what we have talked about. At the end of the day, the malignant tumors, by and large, are actually highly invasive, highly metastatic tumors, okay? Highly destructive tumors, growing without a capsule, as opposed to benign tumors. They say a single picture is worth 1,000 words, right? Look at this. Here is actually a leiomyoma. So one thing that you look here is that the tumor is encapsulated. Two, it lacks any kind of hemorrhage and necrosis. Three, it is not giving rise to any tumor embolus. So you look at the vessels, and the vessels are clear. Okay. Four, the size of the tumor is pretty small. All of those are features of benign C, if you will, of benign tumor. If you take a section of this and you look under the microscope, you will see this cigar-shaped nuclei. Again, cigar-shaped, uniform kind of appearance nuclei. So by and large, this is a benign tumor. Compare that to this. This one is a much larger tumor. So size-wise, it's an indication of a malignant tumor. Two, it does actually have hemorrhage and also necrosis in it. So two features of malignancy. Three, it is invading nearby tissue, as you can see, sending tongues or sheets or cores of cell in nearby tissue. So it is not encapsulated. That's three. Four, if you look at the vasculature, you will see that the vessel here, the tumor have sent an embolus in this vessel, a tumor embolus that eventually is going to give rise to metastasis wherever it reaches. So all of those actually are indications that the tumor that you're dealing with is a malignant tumor. You take a section of this and you look under the microscope, and these cells will look nowhere near what you see in a smooth muscle cell. A smooth muscle cell, as I mentioned to you, should have a cigar shape. Does that look like a cigar-shaped nucleus? Some of them, yes, but the majority are not. So look at these cells. Look at these cells right here. So all of this is actually an indication of a poorly differentiated, in this case, it's a sarcoma. It's a leiomyosarcoma that is metastatic. All right, so now, for the most part, again, benign tumors do not metastasize. Keep that in mind. Malignant tumors, by decree, they metastasize. How will that happen? How do they metastasize? They are going to metastasize by either the lymphatics, the blood vessels, or the body cavities. Now, this is an important actually statement to keep in mind. About 50% of newly diagnosed cancer patients present with metastasis. How about that? That's a huge number, actually. That tells you that the efforts for an early detection, which is the only thing that could help a cancer patient, are failing. If half of your cancer patients are presenting with metastasis, that means your early detection attempts are failing, and failing miserably. All right, so the roots of metastasis, starting with the lymphatic root. Lymphatic root is actually what is favored by the epithelial malignant tumors, the carcinomas. And because of the fact that this is going to actually go from the tumor to the lymphatics, and then into the lymph node, and from the lymph nodes then somewhere else into the lymphatics again, and then into the thoracic duct, and then into the blood. This cycle is going to make actually those patients having a better prognosis. The reason for this, it will take longer to reach the blood than if the tumor simply goes into the blood and goes everywhere else. It will bypass this process. So as a result of that, carcinomas in general have a better prognosis than sarcomas because of this fact. Now, there are actually those carcinomas that favor the hematogenous route, and usually they will have a worse prognosis than their counterparts, even in the same organ that chooses the lymphatic routes. Example of that, follicular carcinoma have a worse prognosis than papillary, renal cell carcinoma, and hepatocellular carcinomas. All right, so eventually everything will go into the thoracic duct and then into the blood, and then it becomes hematogenous, but at least it has gone through this cycle, which has resulted in actually delay in the spread of the tumor. Now, the pattern of nodal spread is going to follow the lymphatic pattern. So if you know your anatomy well, you will be able to easily figure out where the tumor cells are going to impact. And as a result of that, let's say that you're doing actually surgery for someone who have lung cancer. Before you actually decide that if the tumor is going to be operable or not, you have to establish that all the lymph node stations, and those stations are actually divided according to the anatomic flow of lymph from that tumor. You have to decide that all the lymphatic stations are going to be negative for the tumor before you say you can go ahead and actually try to cure that patient by simply resecting the mass in his lungs. Now, some of the criteria for the lymph nodes that are affected with the metastasis, usually they are going to be hard, what you call indurated, indurated lymph nodes. Hard, painless. 3, non-movable, because most of the time the tumor would have gone out of the lymph node and into nearby tissue. And the result of that is going to be like for a fixed kind of, of a tumor. Here's an example of that. So, the afferent lymphatics, bringing it in, the first area that's going to be affected in the lymph node is going to be the subcapsular region. This is the first area right here. This is the first area. Of course, here it's very clear, but a lot of times, let's say if it's a melanoma, instead of the glands that you see here, you have to look for single cells. And that's going to be really, very tedious work for the pathologist. So they will look for the subcapsular areas, and to aid their diagnosis, because a lot of times you cannot really tell what you're looking at if it's a melanocyte versus actually one of the lymph node cells. In this case, you may actually do some auxiliary stains, some immunostains such as S100 that is going to light up those melanocytes and show you that there are actually those malignant melanocytes in the lymph node that you are dealing with. Here it's much easier because you do have actually glands. The glands don't belong to the lymph node. So this is metastatic adenocarcinoma to the lymph node. And you can see here actually that after they go through the lymph node, they have to go out of the lymph node, and that's their exit way outside. Now, hematogenous spread is going to be favored by sarcoma. As a result of that, sarcomas have a worse prognosis than carcinomas. Why? Because it immediately goes into the blood, and then everywhere it goes with the flow everywhere in the body. And there are carcinomas, as I mentioned to you, that do the same. What are going to be affected? What are the vessels affected? In this case, it's going to be most likely the veins. Why? Because the venous wall is actually lighter, is less thicker than and less muscular than the arterial wall. And depending on what you have, the end result is going to be, again, the relationship of that tumor to the in this case hematogenous spread. So for example, anything from the GI is going to end up in the liver. Anything from the lung, anything actually from everybody everywhere in the body is going to go to the lung. The lung, as a result of that, is the most common recipient of metastasis in the body because everything will drain in it. Okay. Here's an example of that. Now, again, just to show you, we will see this in the next lecture. And what you are going to see is that not all the tumor cells are metastatic cells. So this is a vessel right here, a vein, that actually harbor this tumor embolus. If you look at this tumor embolus, you will see that the central part of it is actually necrotic cells. So only the high-grade component of the tumor cells are the ones that are able to metastasize. Only the ones that are able to proliferate and they are able to spread far and wide in a short period of time will be the ones to be chosen, if you will, for metastasis. And that's really, a great example of that right here. So it's showing you a high-grade tumor embolus in this, in this blood vessel right here. Whereas the tumor is nearby. So how come that you're not actually seeing, how the tumor cells managed to get inside? How did it do that? You guys have any answer for that? So here's the tumor. Here's the original primary tumor. How did it come here? Sorry? No, this is a blood vessel. So it has to be direct extension into the blood vessel. Penetration and getting into the blood vessel. Any idea? So obviously what happened actually, the tumor, you're looking at a 3D structure, right? It's a 3D structure. So at one point in time, there was actually a connection between this tumor and the blood vessel, okay? But depending on your cut, You cut it far away from that site, from the site of connection, if you will, or the site of penetration. If you serial cut that specimen, you're bound to actually found, an area where the tumor would have got in, this. So here's an example of, I apologize, I have no idea what happened. All right, anyways, I can tell you what you find here, exactly what you find here, which is multiple metastasis, the pump shotgun, or, remember always Arnold, that will put a smile on your face. That's a very rare occasion actually in medicine and medical school in general. But remember, Arnold Schwarzenegger and the Terminator and the pump shotgun, analogy to this. There's another example of this. In this case, bony metastasis. So bony metastasis, again, like, pathology, probably this is the easiest sign that you're going to be reading for POD. Would you agree with that? Compared to micro and to pharma, probably this is a breeze. I'm sure it is. It does not really need much memorization. It's a logic science. So I think you hopefully you are enjoying it, and hopefully you will do well, inshallah, in pathology and in POD in general. But pathology is so flat-footed, it's so straightforward. So this is actually metastasis to the bone for sure. It looks black. What could be black? What's black in the body? Well, hemorrhage is brown, really, but black. Melanin. So this is a melanoma that metastasized to the bone right there. You see what I'm saying? And melanin, those melanocytes still actually have the ability to make melanin. So as a result of that, you have seen this configuration. This is metastatic melanoma to the lumbar vertebrae. Here's another actually form of metastasis to the lumbar vertebrae, a very common metastasis, if I may add. That's actually prostatic adenocarcinoma that metastasized to the lumbar vertebrae. Now, you will see that in the next few slides. This is actually a type of metastasis that make bone. So it creates bone. Usually metastasis to the bone, you will see the majority of the times, you will see that the metastasis is going to lyse the bone, is going to eat up the bone, resorb the bone. Why does it do that? We will see how that happens, except in two conditions or two tumors. The first one is prostatic adenocarcinoma, the most common site to give rise to osteoblastic metastasis to the bone, followed by the breast cancer. Breast cancer, in a small amount of cases, will give rise to osteoblastic metastasis to the bone as well. The majority of cases, breast cancer will give rise to osteolytic metastasis. So when you send in metastasis to the bone and you start to resorb the bone, what will happen to that bone, in your opinion? It will become weakened, right? So if you apply the same load on that weakened bone, what will happen to it? It will fracture. What do you call that fracture? Pathological fracture, because the bone have been actually weakened. Now, the same exact thing will happen. So this is with osteolytic metastasis. Even if you have osteoblastic metastasis to the bone, that bone that is being laid down new is actually weakened bone. Why? Because it's not being processed. And the strength of the bone stems from the modeling process, the dual action of the osteoblast and the osteoclast. So even the osteoblastic metastasis to the bone is going to weaken that bone. It's not going to strengthen it because it is not being processed, it's not being remodeled, and as a result of that, also that bone will be prone to pathological fracture. All right, so another way actually for the spread is through seeding of body cavities. For that to happen, what you need a space, and you need a small amount of actually fluid in that space. Where do you have that in the body? You have that in the pleural cavity, right? Space between the two pleuras. You have that also, in the peritoneal cavity, and you have also that actually with the, with the subarachnoid space. So anywhere where you find actually a tumor growing in those sites, and the tumor cells are able to reach actually that space and to reach that fluid, they are going to detach from the original site, and they are going to base themselves in this fluid, and they will spread far in that space. That's what you see, for example, with peritoneal cavity metastases that are related to ovarian cancer, especially ovarian cancer. Also, we see it with pleural cavity with prostatic adenocarcinomas. where you're going to see that the tumor has spread as a result, in the pleural cavity as a result of the, of the detachment of those cells and, the bathing, in the pleural fluid. The same exact thing with the glioblastoma multiforme. Here's an example of that. So the end result is going to be that all the surface that are present in that space is going to be receiving these quote unquote implants. All of those implants are metastatic implants, metastatic nodules coming from the original tumor, in this case, from a primary ovarian tumor, the metastatic ovarian carcinoma. Here's a very peculiar tumor, and in this case, it is actually, you have to orient yourself. This is the legs of the patient. This is the head of the patient right here. This is the liver right here. This is a patient who have a primary GI, either a colon or a gastric carcinoma. The tumor cells managed actually to get to the serosa, or to the, to the most, superficial layer of that, organ where the tumor is growing. And then it detached, ended up in the peritoneal fluid, and in the peritoneal fluid, it was seeded to the rest of the peritoneal cavity. The end result in this case, in this patient, one of the folkloric, pictures of medicine is that it reached actually the ovary, and it grew on top of the ovary. So this is a metastatic ovarian cancer. Sorry, a metastatic cancer to the ovary. So then, very important for you to know that metastatic cancer to the ovary. Where is the original? Where is the primary? It is either in the GI, it's either in the stomach, or actually in the colon as a primary GI carcinoma. Okay. Right, bony metastasis. Two types of bony metastasis: the osteoblastic metastasis and the osteolytic metastasis. We just talked about this. Now, the osteolytic metastasis, this is what you call run-of-the-mill. Anything could give rise to osteolytic metastasis. Osteoblastic metastasis, on the other hand, are going to be limited to prostatic adenocarcinoma and to, breast cancer. So what you're going to be finding here is that there are those radiodense, loci on the X-ray when you do an X-ray for a patient with osteoblastic metastasis, and that's actually an indication that there is bone growth in that region. Again, too much of thing is not really good. In this case, those osteoblastic metastases are weakening the bone rather than, strengthening it. One of the things that you may use, to check for osteoblastic metastasis is to ask yourself, what does the osteoblast have in it? One of the enzymes of the osteoblast is the alkaline phosphatase. Every time you see that there is an alkaline phosphatase activity, increased level of alkaline phosphatase in the serum, that's going to coincide with increased osteoblastic activity. In this case, if you see this, radiodense loci on X-ray, in addition to increased alkaline phosphatase, activity in the serum, you call that actually metastatic tumor to the bone, osteoblastic metastatic tumor to the bone. Here are actually some of this osteosclerosis. So instead of seeing usually the fine, appearance of a normal bone, you're seeing a much denser bone, because there is so much bone that is being laid down, new as a result of these metastases from, those cells, that have reached the bone. Now, the tumor cells are not the ones that are going to lay down the new bone. It is actually the osteoblast in that side. How does that happen? At least, what we know about it is that it is due to the fact that those osteoblasts will be irritated by, the invading tumor cells. On the other hand, the osteolytic metastases are going to be actually producing lucency in the bone. So you will start to see, like, areas that have been eaten up have been resorbed in the bone. Why does that happen? In this case, actually, the tumor cells, are, culprit in creating those osteolytic metastases. How do they do it? By elaborating actually materials that are going to activate the osteoclast, either in the form of a PTH-like substance, parathyroid hormone-like substance, or an IL-1-like, osteoclast-like activating factor that is going to activate the osteoclast, and the rest is history. Now, what happened as a result actually of the increased activity of the osteoclast is that there is more bone that is being resorbed. what happened to the calcium level in those patients? It's going to increase. This is why actually you see that hypercalcemia is one of the important features that you see in malignant diseases, in neoplasia in general. Okay? So you know now where it's coming from. So here are examples. Actually, there are there are areas that favor certain areas. Part of it actually for part of the anatomic distribution of the lymph flow, for example. Others are not really well known. Why is that the case? Except that there are receptors actually in those sites that favor that kind of spread. This is it. What time is it? Let's see, do we have time? No, we don't. Okay, so this is it. Any question about this? How do I unmute? Any help? Mute everybody. Unmute everybody. Room, start recording. Hello, Salam. I think there's a good number of questions, right?
Yeah, that's
okay. Please. Go ahead. Okay. If anaplastic cells are extremely dysplastic cells, are they similar to carcinoma in situ? Well, carcinoma in situ is carcinoma. It's simply bound by the basement membrane. So I don't know exactly what you mean by that. They are all malignant cells, except that the anaplastic cells are a higher level of of anaplasia. Someone wrote die.
بكون جاوب على هاي على السؤال.
Die is جاوب.
لا بكونوا انتم اثناء تحكي كانوا.
Seems like a wish actually or something.
لا دكتور بكونوا حدا جاوب على.
Someone is a disgruntled الفيصل student. You never know anymore.
لا دكتور هو اصلا how to differentiate between dysplastic and anaplastic cells.
Right. So how do you differentiate? All right. I just mentioned to you. So like think about this. There is the bad, there is the worst, and then there is the worst, right? So the difference between dysplasia and anaplasia is between bad and worst. Worst is anaplasia. Bad is dysplasia.
طيب. Can doctor explain how the benign tumors develop a capsule?
Right. So there are two ways for that to happen. There are tumors that grow with a capsule. So to have their own capsule, actually true capsule. That's usually the rare, way for things to happen. The other way is that when this tumor is growing slowly by expansion, it is compressing nearby tissue. In the process of doing so, this compressed tissue will create what looks like a capsule, what you call a pseudocapsule surrounding that benign tumor. So they are talking to each other actually.
Yeah,
Can bone metastasis lead to anemia? How will that do it? Yes, very good. Okay. So if there is extensive metastasis to the bone marrow, what's going to happen is that you're going to end up actually with a picture where all the bone marrow normal elements have been kicked out, from the bone marrow. That happens usually, especially if you have, let's say, if you have, a tumor that is arising in the bone marrow, such as, for example, leukemias, acute leukemias, where you will see that there is, far and widespread, or extension of this tumor in the bone marrow. The end result will be that the normal bone marrow elements are going to be kicked out in the blood, and they are going to start to create actually blood outside the bone marrow, what you call extramedullary hematopoiesis. That's going to result in a special form of anemia known as myeloptysic anemia. Okay.
How is this plastic metastasis weakening the bone?
Right, because those osteoblastic metastases are not remodeled bone. So as a result of that, they are weakened. They are weakened. They are simply, they are being laid down so fast because it is a malignant cell that have a lot of ability to make actually, or in this case, actually, it is a benign cell, the osteoblast, that is laying down these new bone. But in the process of doing so, it is not remodeled right away. It's happening so fast. Usually, for bone remodeling to happen, it takes about 10 every year there's about 10 to 15% remodeling of the human skeleton. You don't remodel a bone overnight as a result of metastasis or over a month period. This is going to result in weakening of the bone because the remodeling process is not really in place.
How can differentiate between the neoplastic and the dysplastic cells by the tumor name?
You cannot. You have to actually label the tumor as anaplastic, and this is how you would know. No, neoplastic and wait 1 second. Neoplastic and dysplastic are the same. We already talked about this. I told you for the sake of this course, neoplasia and dysplasia are the same, so that there is no confusion.
Can we say that benign tumors are more dysplastic than anaplastic and malignant tumors are?
No, you cannot. Benign tumors are not dysplastic. Okay, benign tumors are not dysplastic. Benign tumors are benign tumors. This is one. Two, you don't even use the differentiation nomenclature for benign tumor. So you don't say well differentiated benign tumor or moderately differentiated benign tumor. The well differentiated, the moderately differentiated, and the poorly differentiated are only related to malignant tumors. Okay. So in a way, benign tumors are the most well differentiated tumor that you have by definition. So you don't even have to say this is a well differentiated benign tumor. You simply say this is a thyroid adenoma, and the person who's listening to you will know that this is a very well differentiated tumor. Okay.
Can Doctor repeat the parathyroid hormone calcium slide?
Right. So actually, what happened here is that either the tumor cell will be making a parathyroid hormone like peptide, and how does the parathyroid hormone peptide act? It's going to act actually directly on the osteoclast, of course, through the osteoblast, because everything is received by the osteoblast and relate to the osteoclast. Now, this is one. Two, it can do that as well by actually making an IL-1 like peptide, in this case, or IL-1 like cytokine. In this case, it is the osteoclast activating factor like cytokine that is going again to go and activate the osteoclast. So at the end of the day, both actually mechanisms of osteolytic metastasis happen through the osteoclast, activating the osteoclast, either by a PTH-like or by an IL-1 like substance.
Doctor, what is leucine C?
Leucine C, this is what you call, you can see through it because it has resorbed so much bone, you can see through it.
If the carcinoma in situ is bound to basement membrane, why it is malignant?
It is malignant because it has all the features of malignancy. It is full of dysplastic cell. There is dysplastic replacement of the normal epithelium. The only thing that is actually that is different from a cancer is the fact that it did not go anywhere else. It is still bound by the epithelium, contained within the epithelium, but it has all the features of neoplasia.
Doctor, what does alkaline phosphate do in osteoblastic metastasis?
It does nothing. It's simply an indication for you that there is actually increased activity of the osteoblast that will actually, with the radiodense, radiodense foci that you were able to catch, by X-ray, putting the two together is going to give you a good, idea about what's happening to this patient.
In this picture, how would you differentiate that from lung abscess caused by inflammation? How do you differentiate metastasis by?
Well, it could be anything. You're right. It could be. There's, of course, looking at this, you will see that the nodules are usually slighter than what you see, for example, with a TB, mycobacterial TB. But there is, miliary TB that it looks, almost the same like this. But the millets in this case will be smaller. But you're right. It could be anything. Gross pathology is going to give you an idea about what's happening. The solid diagnosis will be when you take a section and send it to microscopic, and that's will return as cancer cells.
Doctor, I mean, if there's a neoplastic like a giant tumor cell, do you still name them the same?
Yes.
Right. Doctor, do we have to memorize the metastatic
No,
sites?
no, you don't. This is just an idea.
Can Dr. please explain the last slide, which column shows the original site? of the
Right. There is
cancer?
no reason. I mean, like I said, it is just for your own information to show you that actually there are, for example, the stomach adenocarcinoma and the virtues left supraclavicular node is one of the follicular actually kind of metastasis in medicine. So if you have it, this is the first, if you are suspecting a patient with gastric adenocarcinoma, this is one of the few actually, or the first areas that you will examine, the left supraclavicular, fossa to look for, this lymph node. And the same thing, with regard to, for example, to the renal adenocarcinoma or to the prostate. Again, it is just for your own information. You don't need to memorize that.
Any other questions? That's it. Thank
All
you.
right, thank you very much.
Thank you.
Can I have
Yeah,
my...
just